All right, let's jump right into this explainer. We're going to demystify the kind of intimidating world of EKG interpretation and really transform those jagged lines into actionable clinical knowledge. If you've ever stared at a monitor feeling totally overwhelmed by all the squiggles, you are definitely in the right place.
Here is our roadmap for today. 1. The alphabet of the heart. 2. 5 steps to read EKGs. 3. Crucial clues for NCLEX. 4. Navigating basic sinus rhythms. And 5. Decoding complex atrial arrhythmias. Let's get started.
But before we look at any actual rhythms, we really need to set the foundation. An EKG is basically just a visual story of the heart's electrical system at work. It's a precise measurement of the electrical impulses that literally command the physical heart muscle to pump.
So, Section 1. The alphabet of the heart.
Every single letter on an EKG has a direct anatomical source. Think of it like a chain reaction. An electrical impulse kicks off in the SA node, causing atrial depolarization, and that gives us our P wave. The signal then pauses for a split second at the AV node, creating our PR segment, before shooting straight down the bundle of His and bundle branches into the ventricles. That massive ventricular depolarization, that creates the QRS complex, which is followed finally by the T wave, representing ventricular repolarization.
To read this alphabet, we literally put it on a grid. Notice how the horizontal lines represent time. Each tiny little square is exactly 0.04 seconds, while a large square is 0.20 seconds. The vertical lines, on the other hand, track voltage. When you combine this grid with our electrical waves, you can perfectly measure the exact duration of both atrial and ventricular activity.
Moving right along to Section 2, 5 steps to read EKGs. You absolutely must memorize this 5-step checklist. Seriously, this is how you systematically evaluate every single rhythm strip you will ever encounter. Sticking to these steps is what prevents you from missing subtle, hidden dangers.
So, the crucial part is applying those first 3 steps without fail. Step 1, ensure the P wave is actually present, that it's upright, and that it comes right before every QRS. Step 2, verify the PR interval is strictly between 0.12 and 0.20 seconds. And Step 3, check that the QRS complex is appropriately narrow, falling within that normal range of 0.06 to less than 0.12 seconds. Because a widened QRS, that could literally signal electrolyte imbalances or drug toxicity.
Let's move on to steps 4 and 5. Step 4 checks the RR interval to see if the rhythm is regular or irregular. Then, for step 5, we just count the R waves in a standard 6-second strip. Multiply that number by 10, and boom, you've got a super quick, highly accurate heart rate in beats per minute.
Next up, Section 3. Crucial clues for NCLEX.
If you're prepping for the NCLEX, or honestly, any major nursing exam, consider this your ultimate screenshot-worthy study guide. As a clinician, you don't just want to spot a weird squiggle on the grid, you need to know the so what. For instance, a prolonged PR interval means delayed conduction. That's a first-degree AV block. ST elevation on your monitor, that translates directly to a massive emergency, a myocardial infarction. And those T waves, they are your prime potassium indicators. Peaked T waves scream hyperkalemia, while flattened ones strongly suggest a potassium deficiency.
Okay, so we know the baseline rules, right? But what actually happens when the heart's natural pacemaker starts to speed up, or, slow down? This is where it gets incredibly practical. Let's use our grammar rules to start reading some actual, real-world stories the heart is trying to tell us.
That brings us to Section 4, Navigating Basic Sinus Rhythms. Check out how perfectly a normal sinus rhythm aligns with our 5 steps. The rate is a super comfortable 60 to 100 beats per minute, the RR intervals are wonderfully regular, and we have perfectly proportioned uniform P waves followed by nice, narrow QRS complexes. This right here is a happy, healthy electrical system. But apply Step 5 to this next rhythm, and you'll immediately notice the rate has dropped below 60 beats per minute. This is sinus bradycardia. The rhythm is still regular, but it's slow. Now, this can be completely normal in highly trained athletes or when you're sleeping, but it can also be caused by beta blockers, vagal stimulation, or even an inferior wall myocardial infarction.
The clinical so what here is entirely about symptoms. If your patient is bradycardic but completely asymptomatic with normal blood pressure, you just monitor them. No big deal. But if they are unstable, dizzy, hypotensive, or having chest pain, you've got to act fast. You reach for atropine as your absolute first-line drug, giving 0.5 milligrams IV push to speed that heart rate right back up.
On the flip side, let's look at sinus tachycardia.
The rhythm is regular, the P waves and QRS are all doing their thing, but the rate just shoots up, typically landing somewhere between 100 and 180 beats per minute. Your body does this as a compensatory response to things like exercise, stress, fever, dehydration, or hypoxia. So the treatment here isn't necessarily slamming them with a cardiac drug, it's finding and fixing the underlying cause.
And finally, Section 5, decoding complex atrial arrhythmias.
Let's step up the complexity. Notice how the nice, uniform P waves are just completely gone here. In atrial fibrillation, or AFib, the atria are basically just quivering at over 350 beats per minute. This creates chaotic fibrillatory waves and the absolute hallmark irregularly irregular rhythm. And because blood pools in those quivering atria, this rhythm carries a massive risk for stroke and thromboembolism.
Just like with bradycardia, your critical intervention depends entirely on the patient's stability. For hemodynamically stable AFib patients, we focus on rate control to get them under 100 beats per minute using beta blockers, and we start anticoagulation therapy to prevent strokes. However, if the patient is unstable, showing altered mental status or severe hypotension, they require immediate synchronized cardioversion.
Now compare AFib to atrial flutter. Instead of that chaotic quivering, the atria are firing in this rapid, continuous circuit at 250 to 350 beats per minute. This generates an unmistakable, highly testable sawtooth pattern on the EKG. It's so fast you can't even measure a PR interval because of those dominant flutter waves.
And then check out what happens in supraventricular tachycardia, or SVT. The rhythm is regular, sure, but the rate is just wildly fast. We're talking 150 to 250 beats per minute. The P waves are often completely buried and hidden within the preceding T waves. The heart is racing so fast it barely even has time to fill with blood.
So what's the overarching lesson across all this material? Whether we're talking about basic sinus bradycardia or complex AFib, identifying the jagged lines is really only half the battle. Knowing exactly how to treat the human being attached to those lines, based entirely on their clinical stability, is where you actually save a life.
You've learned the alphabet, the grammar, and the complex stories of the heart. You now have the foundational tools to look at that monitor with precision, not panic, because the heart is always speaking. Now it's up to you to listen. So when that monitor alarms on your very next shift, will you be ready to translate those lines into confident, life-saving action?